In this video, we'd like to demonstrate some of the arthroscopic findings we use to help make the diagnosis of posterolateral rotatory instability of the elbow. PLRI is the most common form of elbow instability and is caused by any pathology that compromises the lateral collateral ligament integrity and function, and these can be acquired, congenital or iatrogenic, and in most situations the diagnosis is easy to make with a careful clinical examination as shown here. However, in some situations, such as following multiple steroid injections and tennis elbow, the diagnosis can be much more subtle and difficult to appreciate with clinical examination or radiologic investigations, and it's in these patients where we find arthroscopy particularly useful. The arthroscopic findings are concentrated in the posterior compartment and the posterolateral compartment, and these are the findings we'll be demonstrating. Some of the findings in the anterior compartment can be useful but serve as an adjunct rather than to help make the primary diagnosis. We do elbow arthroscopy in the lateral position and typically enter the joint in the posterior compartment. We view from the direct posterior portal and work from the posterolateral portal initially. When viewing the posterolateral compartment and the radiocapitellar joint, we view from the posterolateral portal and make an accessory posterolateral portal for working. So here we are in the posterior compartment, slipping into the lateral gutter, viewing the ulnar humeral joint on the left and the capsule and ligament on the right. With supination of the forearm in the normal elbow, you can see minimal joint gapping, although some gapping is normal. This is very different to the pathologic situation where there's gross widening of the ulnar humeral joint with simple forearm supination. This can be exacerbated by extending the elbow as well. What's happening is that with supination of the forearm, because the lateral ligament is incompetent, there's external rotation of the ulna relative to the humerus, leading to the gapping that we see in the arthroscopic image. We then move into the posterolateral compartment where a drive-through sign can be demonstrated. In the top image you can see a negative drive-through sign where it's impossible to push the scope into the anterior compartment from the posterior compartment, whereas in the bottom image you can see that the anterior capsule and even the coronoid can be seen by driving the scope through from posterior to anterior, and this indicates gross instability and is highly abnormal. In the posterolateral compartment we can also look at the lateral ligament insertion to assess its integrity, and it should be quite hard to get the scope up into this area in the intact situation, whereas in the abnormal situation it's both easy to get into this area and then view that the ligament's torn away from the epicondyle. We can then perform pull and rotation tests in the posterolateral compartment where we're pulling on the forearm to try and create a gap in the radiocapitellar joints, and also supinating and pronating to see if the radial head uncovers itself, and this doesn't happen in this view. This is opposite to below, where simply pulling and causing traction on the forearm causes the radiocapitellar joint to gap open. So these are just some simple logical tests that are easy to perform and very reproducible, and we find them very valuable as an adjunct in the diagnosis of subtle posterolateral rotatory instability. Thank you for listening.